Good afternoon, everyone. As it's 12:30, I'm going to make a start. So it's a great opportunity for the National Center for Health Workforce Studies to be here. And on a number of occasions, we really didn't exist due to Renew ANU, but we are actually doing very well as a small team, and we are the newest department group within NCEPH. And it's been maybe 2 years since we moved here from old College of Health and Medicine. And it's been a really great opportunity for me to learn from you guys and to form a small team and do a policy relevant research. What I'm hoping to achieve today is to talk about who we are and what we do and what approach we take to the work that we do, and tell you about some of the priorities that we are currently working on. And when I finish the first half of the presentation, Marco will take over and he will tell us about the midwifery workforce. Sorry, midwifery workforce project we delivered for ACT. And before I get further into this, I'd like to acknowledge the traditional owners of the land we meet today. Our case, Nanaimo people, others who are joined online, those people, nations who are traditional owners, and pay my respect to elders past and present, and acknowledge Aboriginal First Islander people in the audience today and online. Just going to skip over this. So the faces of people you see on the screen on the top row are the people who work in the National Center. You might know many of us already, but I want to just go through each person. So Mark Cormack and Megan Cahill. Megan is here in the audience. Mark is on holidays, probably in Finland, where the health system is the best. They come from many years of policy experience, and Megan used to be the CEO of Capital Health Network. Mark used to be Deputy Secretary of Health Department, as well as other places that are really highly overlapping with the health workforce research and practice. He also used to be the CEO of Health Workforce Australia. So we started only maybe 4 years ago, but we carry a lot of knowledge base from their work experience before, and my team members as well. Meghana, who is also in the audience, is a statistician, and like myself, Meghana has some experience with the private sector data analytics, and she's a statistician. To the other side of my face is Paul. Paul is also in the audience, is the deputy director of the center. And whereas Mark, Megan, and myself cover Australian health policy landscape, Paul comes from many years of work experience with WHO regional offices. So as a small team, we cover quite a lot of the spots where the health workforce really matter. And me, Tran, Jinhu, and Marco are also in the audience. Me and Jinhu are health economists. And Marco, who will give the presentation, is actuary by background. I was hoping that Jacob can also join. Jacob is our newest team member. He's just started this week with us. He's also actuary, and he is a graduate of this university. I met Jacob when he was working in ACT Health as a health workforce analytic person. And Marcus, to the left of Jacob's picture, he's also in the audience. Marcus is currently a senior manager in Australian Research Data Commons, but perhaps some of you know Marcus as being the Chief Health Data Officer in ACT Health, so you are a senior executive. You worked at NHMRC as well as National Mental Health Commission, and you have a PhD in physiology. So a bit like me, Marcus comes from a cross between public service career plus research experience and real interest in doing impactful research that benefits Australia's equity as well as health policy and program delivery. Talia Abramson is a Research Australia Director of Policy and Advocacy. bit like me, she used to be a public servant, and I met Talia when we were both working on Closing the Gap national policy. Ian Crittenden was part of the establishment team of the National Centre. He also used to have a very senior role in Australia's health workforce. Steve Robson is a former AMA president. He's a medical doctor by training. I think he might be OBGY. He has a dedicated and strong interest still in the medical workforce. And Stephanie Top is a visiting professor. She's usually based at James Cook University, whereas my team tend to focus on technical, numerical aspect of health workforce planning at the moment. Steph has a very political lens. So I think together we can really expand our expertise and lean into each other's skills and experience and network to do larger scale work. And Jim Buchan is usually based in Scotland. He is a senior fellow at Health Foundation UK. He came to Australia recently for the National Centre to deliver the masterclass in health workforce planning. That's Jacob in the background. I just introduced you before. And there are many pictures of people who we work with, but I didn't have a place to put in there. But because health workforce research, policy, program delivery is a big scope of work, we have many other people, many other organizations that we work with. I have a slide of list of people, a list of organizations, which I will show you later. Okay, my next slide. So why does health workforce research matter? It's because it's a issue for Australia as well as our regional neighbors and more globally. We have a supply issues. We have maldistribution of existing workforce, and Australia rely heavily on international medical graduates as well as other health professionals who are trained in other countries who will come to Australia to care for Australian people. And we have to really start to think about what does that mean in terms of our contribution to our region, and also individually. And health and care workforce work across health sector, aged care sector, disability sector, and more. So there is like an intersectorial competition. Not that long ago, while I was doing meditation retreat and relaxing, Minister Butler announced the big changes to like NDIS and aged care. So when something like that happens, there's like a whole raft of like things that has to come through, work through after he makes an announcement about how we're going to work on this big gigantic problem of issue of health and care workforce and the care provision. And better evidence is needed for better policy. And as many of us know, evidence-based policy is very important, but policy will be made with or without evidence, whatever we think or not. So it's very important for the team I lead to be working closely with policy departments and community organizations and consumers and all sorts of different groups and lenses and perspectives so that the policy that gets rolled out is effective in terms of achieving health equity, care equity. And the role of the National Centre is to conduct impactful research, capacity build in terms of research skills, policy skills through education, executive education, as well as we are working on master's level course with the help of Katie and Bell, and work with PHMs and other organizations who have a stake in health and care workforce, or working out to be of relevance nationally, regionally, and globally. And I just had a very good news from Paul just now, like 5 minutes ago. We worked on a WHO funded project last year. It was a very big piece of work, and it's got to do with unmet healthcare need. And it just got published on the website. That made me feel really happy. Thank you. And in fact, somebody who's in the audience today and other people who are not here have asked me in the last couple of years, Tomoko, how did you get your job? Like, it's a very good question. So the next two slides are a little bit about me. The dot points you see are based on my role description. I recently had to apply for my job, and the summary of what my job is according to the position description is on the screen. But in my own words, my job first and foremost is to create a safe environment for my team members to do the job that they're hired to do. In terms of finance, in terms of professional development, in terms of psychological safety, in terms of professional development in leadership and management skills, aside from research skills, that's definitely my job. And obviously to grow the center and conduct impactful research, provide education and capacity build across sectors. There's another thing that really is very close to my heart. Marcus, who's here, and Jacob, we have recent policy experience. We would like to see more coming together of research and policy, and it's very difficult to do because we're not in the tent of policy making. Policy makers who can better work with research insight and data analytics in the future is very important for something like health workforce issues to be dealt with. And it's very hard to influence this. And it's not like I have a solution to this problem, but I just know that in the next 5 to 7 years, that's what I'd like to do. So executive education is a one really good way for us to spend hours together, to understand each other, like to turn no to like yes via tell us more. Like we want people to become curious about why we do things, why we say things. And also for the research sector, AMU, for example, it would be so much more easy to do good research if we are more informed by policy making. So only a couple of days ago, the national budget got announced. People who worked in policy have a skill in analyzing what does that mean for the part of the work that I do. So I asked Megan after the budget to create the briefing paper for the center staff to be able to consume. So we understand where there may be a new opportunity, where there may be new risks, so that we can be informed by what is about to happen in 2026-27 financial year. Okay, and the next one is about me. So I started my professional career in mental health epidemiological research in Japan. At National Institute of Mental Health was where I started my career. And it was very interesting there for me because I went to University of New South Wales to study. I recently discovered Phil Badham, and I have the same undergraduate degree, 1 year apart. Like for me, it was like a reverse culture shock to be working in Japan, where the training in psychology was different to mine. I learned a lot there, but after some years, I went back to University of New South Wales to do PhD in psychology. My psychology was a cross between organizational psychology and social psychology. I looked into cultural adjustment of expatriate managers and international students and how that affected people's educational outcome, work outcome. And after some time, I wondered, like, what do I want to do with my career? And then I somehow landed with management consulting. And each of us have a complex feeling about management consultant right now. And I want to say, I left there for a reason after 6 years of working, but I learned a lot about how to engage with risks. And this was very important because the next job after that was in public service, which tend to avoid risk altogether. So engaging with risks is a very useful skill. And I learned a lot from doing that. And my job there in management consulting was actually helping pharmaceutical companies strategically deploying their sales workforce. And some of them are like Pfizer, AstraZeneca, global companies who wanted to enter into China. It was early 2000s, so China wasn't China today. So people didn't know where the cities were, like how to understand the Chinese health system, and that was my job. So it's still useful today. And in public service, I worked first at Australian Institute of Institute of Health and Welfare, and I really only worked on health part of the institute. I reported on nearly all chronic disease, and my area of work was data development, governance, and reporting. And after some time, I thought I want to get closer to action where the decisions are made. So I crossed over to the Department of Health and Aged Care, as it was called at the time. And I had the pleasure of working on First Nations primary health care policy, and I was a data lead there. And then I have my job now. This isn't my job interview, but my job interview wasn't that long ago. And I honestly believe this looks like a hodgepodge of like cross-sector movement, but it really helps me to do my job now. So everything that I learned is very useful now. And it's really good to know that you can change sectors and still kind of continue to enjoy like a growth as a professional. So that's been my journey. What I have on this screen on this side is the enablers that I think it's very important to acknowledge. This kind of goes in circles, and that's why it's organized in like a circular shape. And I'm going to go with vision. Vision is something that we set for ourselves as a North Star, like we want to do this. And in our case, in our National Center, it's to conduct impactful research, provide education, capacity build, and create a ecosystem of evidence generation and policy implementation. And we need funding to do this. And as you probably all know, we started our life with the Transform funding. That was very useful. But we also now have quite a lot of external funding that can support our work. We have funding from responding to requests for tender, and funding from grants, and funding from executive education. And our partners are the people and organizations who share the same goal or similar goals. And we work together to achieve mutual objectives. Probably I don't need to go into capacity, capability, teamwork, but it's really important for my team and any team. But especially under Renew ANU, I find these three things to be very important. National Center used to be probably twice as big as now. And each time I lost team member, I couldn't backfill because I wasn't allowed to use the externally earned funding to do that. And we work really well as a team, and I feel really proud of the work that we do together. What's on the other side are things that I feel I learned on this show. You guys probably learned this a long time ago. So good things take time. In public service, we are really familiar with working fast. So like lots of things feel like happens fast. It might not look like that to you guys, but it does require, it's like, oh, got to get done in 2 minutes, really fast. Good things take time because for us to get to know people and organization takes time. For other people to get to know us as people and a team, it also takes time. And funding a grant cycle is annual. So if we miss out on something or if we don't get it, then we have to wait another year to go for that again. And to repurpose what we didn't get funded for another grant also takes time. So like totally my learning, good things take time. And gaining another perspective is really important. We all try to do interdisciplinary, transdisciplinary research. And because things take time, it's very important to hothouse ideas sometimes. And I'm going to tell you about this Japanese kind of like journey I am on, my team is on, even Marcus is on. And I'm gonna try to like talk to you this slide a little bit in detail so you know what you're looking at. So this colorful one doesn't look up so well. So on x-axis is years. It starts from 1813 and it goes to 2015. So in 5-year blocks or so, you see that years. And the colors are age groups. So the green down the bottom is young people, 0 to 14-year-old. Blue is 15 to 34-year-old. Light blue is 35 to 64. And orange is 65 years and over. This is the Japanese data. This is one way to show a population pyramid. So as we go along from 1813 to like more recently, 2015, the shape of the population changed. There used to be many young people, than the bottom below the x-axis, but now there's more orange. There's lots more old people, more dementia, more care need. If this was Australia, we might be thinking we need more migrants. But Japan, Japan has the same problem we have, like productivity loss, reducing, declining birth rate, like the war happening, lots of different things. And I find Japan really interesting, partly because I'm from there, but because the problem solving is different. I'm so far away from saying that we can do what they do or what we should do what they do, but it helps me think about Australia in a new way. Japan adopted robotics and AI a long time before we did, or we do. But Japan is not multinational, multicultural society. Last time I looked, 97% of Japanese people who live in Japan are from Japan. So only 3% who are not from Japan. And they largely from Korea, North Korea, and China. So we really blend in. And like us, Japanese care and welfare system was developed somewhere between 1960, 1980, that kind of timing. So it was before the population pyramid change. So they're dealing with how do we reform care and welfare system that was built many years ago when the Japanese society looked different. That's like us. That's like strengthening Medicare as Japanese version. And I just put the comparison between Australia, Japan population pyramid next to each other. So Australia is aging, but Japan is super aged already. And at some point, Australia might face what Japan's current reality, like depopulation of rural areas, a commitment to caring for all different places in Australia. So I find this to be very interesting. And we have a Japanese collaborators who came to visit us last July, and they met with ACT, senior executives, chief medical officers, etc., and met with people who are from NCEPH and all College of Health Medicine and AI researchers. So that's just in the making, and it takes time to get to know them, takes time for them to get to know us. But I think in health workforce context, at some point, AI in clinical medicine, AI used in health policy, and like the more traditional workforce planning will merge. And I would like to be ready to be working with them when that happens. And this is just a list of funders and collaborators. I might not dwell on this too much. We have quite a lot of funders and the ones that we are working with or working towards. And this is like a very quick list of national centers priorities. Got to do education, got to do more impactful research and strengthening partnership, and for me to work on the sustainability of the center. In all of this, I was hoping that you feel like you know us better, and I like to be working with many of you, like mental health research, First Nations research, like climate change. There are many things that NCEPH does that has a connections to what we do. May not be something that we are interested in currently, but in fullness of time, I'd like to be collaborating more with NCEPH researchers and more broadly across AME. At this point, I'm going to ask Marco to take over. We might take questions at the end maybe so that we can just focus on delivering the message.
All right. Hi, everyone. I'll show you a project that we have done with ACT Health, where we project midwifery workforce demand using a macro simulation model. So this work was done, but before I actually go into the project, I'll just do a general introduction on health workforce modeling, since I'm not sure if you are familiar with it, but health workforce modeling is basically to project the supply and demand of health workforce given a set of planning assumptions. And for supply side of the modeling, we normally use a stock and flow model, which is pretty intuitive. And for the demand side of the modeling, we normally use either utilization-based model or needs-based model. For utilization-based model, it's very intuitive. We just use historical utilization data to do the projection for future utilization, but that will ignore the unmet needs part of the health services. And for needs-based model, we normally go from like disease prevalence and then develop all the future service needs. And then it's important to do scenario planning as well, where we can test all the policy parameters and things. So this is the general idea of health workforce modeling. So normally when we do a project, we will do both supply and demand and to compare to see the future gaps of health workforce. But for this specific project, we are only looking at the demand side of public sector midwives in the ACT. And the key goal is to analyze the policy scenarios of pregnant people. They prefer to have continuity of care midwifery model. So that's what we want to test. If we are going to increase the percentage of people accessing that care model, then how many midwives we would need in the public sector. So this is the overview of the project. Our approach is to develop a macro simulation model, mainly because we got unirecord data on the national perinatal data set. So we are able to simulate the pregnant populations through their clinical maternity care journey. And I'll just go to the motivation. So first of all, in the enterprise agreement, we have the mandated staffing ratios. As you know, like there are midwife to patient, nurse to patient ratio, but also midwife to patient ratios in the hospital wards. So that's something we need to consider. And also the continuity of care midwives, so they also have annual caseload, maximum caseload in the enterprise agreement. And for the care preferences and policy commitments, there's a government commitment to expand access to continuity of care model. So what is continuity of care midwifery model? It is a model where a woman or pregnant person receives care from a known midwife through their pregnancy journey, like antenatal, birth, and postnatal period. So the benefits, there have been a few studies on the benefits where they have better birth outcomes, better satisfaction for both consumers and midwives, and it's more cost effective compared to other models. So there are a lot of evidence on the benefits of this model. And there is also a rising preference among pregnant people for this model. So that's why the government is committing to expand this, expanding access for this care model. So our research question here is, what is the future demand for the public midwifery workforce in the ACT, including continuing care midwife and non-continuing care midwife? And the sub-questions, what are the main drivers? Or how can a macro simulation model be developed to project the care needs for pregnant people? And how will policy changes affect future demand? So I'll just briefly talk about the considerations that we include in this project. So one thing that's pretty, well, first of all, population and fertility rate, of course, we need to consider that. That's the most basic things. But what's unique to ACT is, one is cross-border birth, because about 16% of people giving birth in ACT actually are from New South Wales. And they tend to be more high-risk pregnancies because only high-risk pregnancies are referred to ACT. So that's one unique situation we need to consider. And policy commitments, like mentioned, there is a government commitment on expanding the continued care midwife model and the mandated midwife to patient ratios. We need to include that in the modeling to make sure that we are calculating the correct demand for midwives working in the wards. So for this model, we're going to use the needs-based approach. So what that means is that we will use a macro simulation model to simulate all the pregnant people. And we assume that they will receive the recommended level and volume of care. So we're not using the historical service utilization. Instead, we are using the care guidelines to decide how many services those pregnant people will receive. So, for example, the national care guidelines says that pregnant people should have at least 10 antenatal visits. So even though in reality, some pregnant people, they might skip some of the antenatal visits, but in this model, we are assuming that everyone receives the recommended level of care. So that is the needs-based approach. In this way, we are actually projecting the services that's needed by the people, not historically used. Okay, so we have this maternity care pathway. So for a pregnant person, first of all, they will be categorized as low risk or high risk, and their risk level actually decides what are the care model options for them. So for continued care, it's available to both low risk and high risk people, but mostly for low risk people. And another most common care model is maternity teen care. Basically, you just go to the public hospital, to their outpatient maternity care clinic or some outreach clinic. And we also have GP shared care. And for the high risk pregnancies, they normally go to fetal medicine unit or specialist teen care. And then after assigning those risk models, they will have antenatal visits and then antenatal stay in a hospital. And there are different labor onset types and birth methods. And then they will have postnatal stay in the hospital and then postnatal home visits. So this is the whole maternity care pathway. And what the macro simulation model is going to do is that they will simulate this whole journey for the pregnant people. And very important thing is that in this care pathway, you can see some later stages. For example, birth method, it actually depends on the labor onset type. And it might also depend on the risk profile of the pregnant people. So actually, when we simulate the later, for example, birth method, we will have the previous dependency variables. So that's the idea of this macro simulation model, also why we use the macro simulation model. Okay, and in this journey, most services are provided by midwives and of course some by GP, some by obstetricians. But we are only looking at midwives. And another reason that we can use this needs-based modeling is because midwives are their main scope of work is in this maternity care pathway. They don't really do other kinds of work. So that's why we can use just simulating this care pathway for all the pregnant people and use that to estimate the demand for midwifery workforce. And because we are separating continuity care midwives and other non-continuity care midwives, so continuity care midwives, they basically provide care across all key stages, and estimating their FTE is pretty simplistic because they do have this 40 pregnant people per FTE per year in their enterprise agreement. But for non-continuity care midwives, they will work in the wards, they will work in the outpatient clinics. So we need more productivity data on like how much time they will spend for each antenatal visit and how many midwives are needed in those antenatal and postnatal wards. So that's the consideration we have. And the modeling framework for the first stage, we will simulate the pregnant populations. We have the population projection and fertility rate assumptions. And the second stage is that we will estimate the care pathways. So we'll just assign the maternity care pathways to represent how pregnant individuals interact with antenatal birth and postnatal services based on their demographic and health profiles. So one thing I want to mention here is that actually the care models will interact with birth methods and then postnatal stay as well, because there are evidence like I previously showed, that continued care model will decrease the rate of cesarean section and increase vaginal birth. So this change in probabilities are all included in this simulation. And then the stage 3, we will estimate the workforce demand. Basically, we will convert all the projected maternity service requirements into the FTE for midwives. And stage 4 is to test against scenarios. And for this one, we are mainly looking at the policy drivers, which is the care model allocation. And I'll show you the key findings. So for scenario A, we just assume that access to the continuity care model remains unchanged at 2012 level. So this is the projected FTE of midwives. The light purple one is non-continuity care midwives, and the deep purple one is the continuity of care midwives. And because the population in ACT is increasing, but fertility rate is decreasing, so we end up with a pretty stable increase for the demand of public midwives. However, if we look at scenario C, where we assume a policy setting that access to continuity care midwife model increased to 50% in 2028 and 75% in 2032, then of course we will see a decreasing in the non-continuity care midwives because and the increase in continuity care midwives. But also another important thing to notice is that the total FTE of midwives will be higher compared to the previous scenario. It's because continuing care midwives, they need more time to provide that comprehensive personal care to pregnant people. So that just indicates that if we want to expand access to continuing care midwifery model, then we need to make sure that we have enough supply of midwives in the future to cope with the increase in demand. And if we compare 3 scenarios, only looking at the total FTE of midwives, then we can just see the 3 policy scenarios. The purple one is the mandated ratios only, so no change in continuity care model access. And the middle one is 35% continuity care model in 2028, and the orange one is 50% continuity care model in 2028. So you can see the difference between those 3 scenarios. And that's basically the policy implication we're looking for, the evidence. So summary findings, the future demand for public midwives is projected to be relatively high, and mandatory ratios define the baseline of workforce demand because even pregnant people under the continuity care midwifery model, when they are admitted into the antenatal and postnatal wards, the service will still be provided by non-continuity care midwives. And continuity care midwifery model coverage expansion will drive the rate of increase in the demand. Transitioning to more continuity care midwifery model leads to a larger increase in demand for continuity care midwives, but also increase in the total demand for midwifery workforce. So that is the summary findings. some limitations on future research. Limitations, first of all, we use static assumption for many variables. We're using the 2022 levels instead of incorporating the trend. Second one, we have simplistic risk classification. This is just because there's no clear clinical definition on who's low risk and who's high risk. And often that will involve other non-pregnancy related conditions, which is not in the data set we use. So we have to simplify that definition. Exclusion of cost considerations, which is an issue raised by midwives when we do the consultations, but we don't have relevant data for that. And lack of socioeconomic and geographic variation, just because ACT is relatively homogeneity in this kind of areas. So actually, we are currently trying to transform this into a publication, and so questions and feedbacks are welcome. For the paper we're working on, we're going to change this to a national level projection, just to first avoid using the ACT provided data. So we're going to use the national public and perinatal data for this. And we are going to change the first limitation. So we're going to include trend in the some of the variables. But yeah, that's the changes we are going to make for the publication. And any questions and feedbacks are welcome to help us develop this paper. Thank you.
So we are now like 1:15. So we have some time for questions and answers. Any questions or comments from the audience? Yes, Nick.
Yeah, for a very nice presentation, Michael. Was very interesting to see these data. I've got two questions. One, on your figures, there was no uncertainty parameters, confidence intervals. And so my first question is, how confident are we about these numbers? And do you try to compute not just uncertainty intervals, but also have scenarios where we say, if we 5% more on these things, or because it's not just about the uncertainty, it's about doing completely wrong or policy changes that change dramatically the assumptions. So that's my first question, how do you deal with that?
Yeah.
The second one is, I noted that you were very careful about inclusive language for people who are pregnant, but not with midwives, which intrinsically their name imply. Is it something that is being discussed? I just popped into my head as I was listening to the talk.
You want to capture the question? We have to capture the question for the microphone.
Yeah, sure. So first question. So first question is that we actually did some sensitivity analysis for this project. I just didn't present that because for the population projection and the fertility rate, they both have low and high series, and we do use that to make some scenarios. But for the publication, our plan is to actually transform those high and low series into a distribution, like a normal distribution or something like that, and include in a macro simulation model. And then our projections can have some prediction intervals. So I think that will look better for the publication. Thank you. And for the second one, to be honest, I'm not sure if we have an inclusive name for midwives.
But good question though. So that for the record and also online for people, the question was around the use of inclusive language for people who are pregnant rather than pregnant women, for example. This is something that we worked with the funder, the ACT Health midwifery chief midwifery officer. So I guess that part was like front of mind. So like, and it's also slightly cumbersome for us to still say because it's a relatively new reference. But Nick's question was like, why not like more inclusive language for midwives? Because it's like referencing women. We don't know, like Jacob used to be a project manager on our client side at the time. So Jacob might have a reflection.
I think the one would be a very hard one to change because I think it's a protected title. So under the legislation that has to be named. So I don't think you could actually change that legally. Whereas for the other one, we do intentionally make the change throughout or as well to make it back throughout. So yeah.
Thank you. So for the people who are listening online who can't hear, there are 16 health professions in Australia which are nationally regulated and they're called protected titles. So there is like probably quite a long process to change any of these names. So that was like a one answer. Thank you, Jacob, for contributing. And Emily, yes.
Now, I've got a comment on the previous question. So thank you very much. Actually, Tamaka, it was really fantastic to hear the gestation of your centre and to hear the kind of the background story of that. I think we don't tell those stories enough. I think people just go to our own on the big success and we don't hear about this other part. So really appreciate that and being introduced to the team. So thank you very much. I think I've been in forums where the discussion about the term pregnant women and pregnant person have been discussed. And it is actually contested to some extent because the vast majority of people living there are women and identify as women. And there are concerns that using the term pregnant person, it's not a neutral state, not neutral in that maybe more inclusive for the people who are non-binary in terms, but it also can be seen as erasing women in that scenario. So I think that's another thing to just factor in. It's not, so there are environments I've been in where there's actually been a decision to use the term pregnant women for that reason. So I'm not going to comment either way, but I think it's really, often we think we're doing something that is benign and required, and you have people in the room who want it to be a particular way, and then there's other conversations that it's useful to be conscious of. So I've got a question about the extent to which you do proactive work or comment politically on things, because I've just noticed that today, I've seen the news today that Ms. Taylor said that under the coalition's now having a policy position that migrants who are not citizens will not be entitled to certain benefits. And I would imagine, so he said it's not related to health, so obviously we'd be able to go to the doctor, but it's things like disability pensions, odd study, and family tax benefits, healthcare cards, those sorts of things that will not be available to non-citizens. And obviously, my first thought is, wow, that would be new stuff on their health workforce, because people who are migrating to do these jobs have choices. So I'm just wondering the extent to which your centre might be either contacted to provide data for that, or might proactively decide that this is something of significance that it might be read proactively.
Okay, thank you, Emily. So Emily's first thing was a comment about the inclusive language. So I will take that as comment. So thank you. That was very important to acknowledge. Second question was about whether or not we have a priority to proactively engage with topics such as the one that Angus Taylor made an announcement about. Certain migrants may not have access or will not have access to social entitlements, like welfare payments. I haven't really, non-citizens. Thank you. I haven't really been across that as just yet, so it will be something for me to look into. These are things that my team members and I talk about often. If you can remember the pictures of my center, we are made of people who are not from here. except for Megan and Marcus and Mark. And it really is important for us to continue to have this conversation. And I'd say Marcus, Angus Taylor was not part of the university's core process because in the figure 1 is basically how big is each of the sectors, and health and care sector is the biggest one. 16% of Australian people work in this sector. And figure number 2 was that which of these sectors will have to grow faster than any other. And by far, number 1 is social and health, health and care sector. So I think he and his supporters will have their views and values, and they're trying to appeal to their political support base about who they are. And I think personally, we should do the same. And also, this is a very fresh proposition for me. I'm still a public servant, but I'm going to resign from that. So then it's, yes, exactly. And Talia from Research Australia invited me to write a paper, and it was 800 words. And I was like, my goodness, I've never done this before. I felt like I had to just hold back like so much while I worked as a public servant. Now I can sit, I can have an opinion, and it's really, really wonderful. So I will not forfeit this newfound freedom. So that's very important for me to acknowledge. But I just go back to the circular figure that I showed you. It's really based on what you and I talked about before. You inducted me into my job, and it's very important to select which opportunity we go for, because there's always an opportunity cost. If we sink effort into something that we're not going to be able to get funding for, it has to be a very special kind of decision. So I have to think about what things that I can do in this kind of like still renew a new era that we are still so living under. And I just also go back to what I was saying earlier about good things take time. I like this, what you suggested, to be a thing that we would do, but in good time. May not be something I can do right now, is my honest answer. Thank you. And Hilary has a hand up.
More a couple of comments rather than questions. First of all, I'm not sure Angus Taylor has done the modelling on what would happen to tax if nonsense. So just to comment on that, and the other thing I wanted to just sort of say is just a massive thank you to Tomoko and all of the health workforce team, because it has been an extraordinarily difficult 2 years, I would say, with you and your team, and just the absolute, dedication, hard work, and unstoppableness, I have to say, to have sort of worked through all the trauma, really is one of the key words, but all the uncertainties and all the funding issues and everything, and to be in this extraordinarily, I think, very strong place that you've come to now, like small but mighty. And with an absolutely, brilliant, bright future ahead, and that really is down to the absolute, your leadership, Tomoko, and just the hard work. So thank you.
For people who are listening online, so that was very nice. I don't know, like words of warm words from Hilary. I can't even say like exactly what you said. So, but thank you back to everybody who's here and who couldn't make it today. Without the support from NCEPH, especially when we started our life as a College of Health and Medicine people, on 1st of October 2024, each of my team members got told by Rebecca, we are proposing we will discontinue role because you don't bring in enough. So that was a really traumatic day, and I don't think I will ever forget that day. And that was the day Megan and I came back from mat leave. It was a really bad day, and I'm so glad that we are still here continuing to do our good work. And I hope to be able to continue to work with you and do more things together. And there are lots of things we are learning collectively, and me as a person. We recently did an executive education masterclass. That was like a colossal effort. It was like so much effort. But I really like having done one. It's like, okay, I know how to do this one. So if any of you want to do this, I learned how to book good venues. And also Hilary's team helped us to do the administration. So we are also indebted to each of you and all of you. So thank you. Let me just check that time. Maybe it's time to to wrap up?
Maybe we can take another
Okay,
question.
sorry, there's one more question, please.
Thank you very much, first of all, sharing your themes, people, with a place there, so we can recognize people too, and of course, sharing your work. Thank you very much for that. I wish we could have more of these sort of, centers introduction. So thank you very much for that, and thank you to your team working on these very important sort of aspect of our sort of society. My question is around your project for midwifery. I know you mentioned call, so that's the area that I am working on. And you mentioned the exclusion of code consideration as your limitation. I'm curious to know what sort of consideration you are thinking, and again, going to more inclusive language. Isn't it better to mention those variables instead of combining all of those in one term code? Thank you.
Yeah, so I think for your first question for population, what we have heard from midwives during our consultations are that it will generally take longer to provide services, especially antenatal services to them, and they need better like culture training, like midwives. They will need additional training for handling those cases and handling the culture sensitivity. So from the workforce demand perspective, that means to provide service to population that will require more time and more training from the midwives. So that's the main consideration we would like to incorporate if we have the data for it.
Thank you.